This talk will cover a very simple approach to a general anesthetic in a district hospital setting. Now, general anesthesia is a complex process with lots of moving parts, and I don't think any specialist anaesthetist can ever use exactly the same recipe because patients and procedures vary. But in the beginning, while you're learning, a fixed recipe with fixed steps might be a good way to learn an outline. And after that, you can fill in the details and start to adjust that basic recipe. I'm going to end this talk with a recipe that's as close as I can get it to a beginner recipe that will work, even if it's not the most elegant anesthetic in the world. Now, there are 4 basic elements to every anesthetic, and you need to be disciplined in doing all of them. And I'm only going to give 1 slide to 3 of them and then focus on the anesthetic component. So the first thing is you need to examine your patient, and that's the patient and the investigations. We need to prepare well, and that's equipment, the drugs, and the staff that are involved in the theatre. We need to get through the anesthetic, which is an induction phase, a maintenance phase, and an emergence phase. And then we need to recover the patient properly and look at the stability of the patient and develop a post-operative plan. And I'm just going to focus in this talk on the anesthetic issues. Now, if you are a beginner anesthetist, you really need a good pre-operative assessment. Your anesthetic recipe is defined by this, your doses are defined by this, so don't fall into the trap of anesthetizing an unassessed patient. It's one of the things you can control. Now, it doesn't have to be an exhaustive pre-operative assessment, but make sure you do the following components. So first of all, you do a general exam, and you make up your mind at the end of that general exam, is my patient sick or healthy? And just even labeling the patient sick will trigger a bunch of drop-down menus for you, which include lightening your anesthetic, which dose you pick, which drug you pick. Always listen to the heart. This is a trap we sometimes fall into. We don't use our stethoscopes. A loud murmur fundamentally changes what we're going to do. And while you're listening, you will pick up the rate, so you will pick up tachycardic patients. And then examine the area. And there are 3 areas we assess in every airway examination. Am I going to be able to mask ventilate the patient? Can I intubate the patient? And can I do a rescue airway? And how to do that airway assessment is in one of the other videos on the channel, but also I will go through it in a more detailed talk later this year. The next thing is have a look at the vital signs: heart rate, blood pressure, oxygen saturations, respiratory rate, Glasgow Coma Scale, temperature, and have a look at the investigations that you've got. Now, this doesn't have to be exhaustive. Many patients just need a ward hemoglobin before the operation, but if you've got investigations, have a look at them. And then remember, what is the operation for? So some operations are minor surgeries, in which case your anesthetic can be tailored to that. But some patients, like the picture I've put up there, might have placenta accreta spectrum disorders and can be expected to bleed. So even though the patient looks well, your anesthetic has to be tailored for a patient who could become unstable. And those basic things in the examination, doing a general, listening to the heart, looking at the airway, taking notice of the vital signs of the investigations, and thinking about what operation you're going to have, that's all you really need for a basic pre-operative assessment. The second skill set that you need is to prepare well. And again, this is something you can control. And you've won a lot of the battle if you induce an assessed patient in a prepared environment. Now, preparation is a discipline, but it's absolutely vital. Decide how the patient condition and the patient procedure are going to alter your theatre prep. And remember that theatre setup involves making sure your equipment's ready, your drugs are ready, and that your staff are the appropriate staff to have. Now, you can go and look up which emergency drugs to draw up. That's also in this video. There's a little 5-minute video on which ones you should have drawn up. Remember that emergency drugs, you actually want to draw them up, not just have them available. And this is because when things go wrong, especially as a beginner, you want to reduce the number of steps you have to take before you can take action. Airway trolley check, 5 or 6 plastics, 5 or 6 metals, depending on the system that you use. Again, there's a short video you can revise. Check your anesthetic machine. And as I always say, I check my anesthetic machine, not necessarily the full machine check, but I check that I can generate a pressure when I'm doing manual mask ventilation. And I always make sure I have an ambu bag that's working. I have a flexible, a suction system with a rigid suction catheter, a Yankau, and I have a spare oxygen source. Those are the basic things I check. And again, we'll cover detailed checks of this equipment in a separate talk. Now, you want to prepare well so that you can reduce your cognitive load. Beginners need less to focus on. So one of the things that I advise is that you work out all the doses before you start. Have everything ready so that when you start, these things are all drawn up, pre-drawn. I actually advise beginners to get a piece of paper and write down every drug they might give. What is the dose per kilogram? And then for this patient, what would that dose be? So you don't have to be calculating these things while you're giving the anesthetic. If you've got checklists, put them up on the wall, laminate them. If you've got a friend who knows what they're doing in anesthetics, bring them along. When you're a beginner, you need to build in these safeguards so that you don't get into trouble. So reduce your cognitive load where possible. Now, general anesthetic is actually really, really simple in concept. You position and pre-oxygenate the patient. You induce, intubate, and put the patient on a ventilator. You maintain anesthetics, and then you wake them up. And in steps, it's quite simple, but the step I think that everyone gets most concerned about is this step, where you are putting the patient to sleep, intubating the patient, and putting them on a ventilator. That's probably the step where the most complex things happen and there's the most hemodynamic instability. So that's the step really that you need to work on. And in the district setting, you need to find ways to practice what scares you. Now, actually, many of those steps you can practice. Intubation, you can practice on dummies. You get intubation experience when you do resuscitations, and you should always try and intubate during resuscitation if the situation allows. So those are ways you can practice. And then when you've got someone who's experienced in anesthetics in your hospital, go and see if you can pinch the intubation, because these are the things you need to be slick at. If you want to practice ventilating, you can put a false lung on the ventilator. So that's just the bag that you use for manual ventilation. You stick that on the end of the circuit, and you can set the ventilator so that these things are not new skills you're learning while you've got a patient in front of you. This was our attempt to provide a simple recipe. So the reference is at the bottom there, and we were providing a list of options for you if you're going to anesthetize a ruptured ectopic pregnancy, a patient who's had a ruptured ectopic pregnancy at district level. And you'll see we've broken it down into the pre-operative preparation, and there's induction options, maintenance options, and emergence. And what you can do is print out something like this and stick it on the wall. And if you think, okay, I'm about to induce, you go and read the options for each one. And I'm going to pull some of these little bits of advice into this talk as we go along. Now, remember positioning. It's so important. Always position the airway as if it's going to be a difficult airway. And the more of a beginner you are, the more important this is. Now, you can see on this patient is lying flat. If we are trying to look for the vocal cords, we're looking at right angles to where the airway is. And we need to position this patient better. And there are two ways you can do this. You can use pillows to get that head forward relative to the chest, and a little bit in the morning sniff position. And you can see the angle now that you'll be looking at the vocal cords is no longer at right angles. So you want that mastoid process in line with the sternum. And the simplest way to do this is with pillows. You can actually do it with the bed. So you ramp the head of the bed, and then you just take the head piece and put that parallel to the bed. So either way, what you want to do once you've positioned your patient is walk along the side of the bed, have a look from the side, and make sure that you've maximized that thyromental distance. You've got the head forward, and the mastoid process is level with the sternum. If you have to reposition your patient during intubation, remember that that's obviously because you didn't position right the first time. So this is absolutely critical to get right. The second thing you really want to get right is you want to pre-oxygenate properly. Look at the seal on this picture. This person's got a really tight seal. So don't allow a loose seal. You pre-oxygenate with 100% oxygen, and you need to do it for long enough. Now, either time yourself, it's 3 to 4 minutes, or better still, have a look at your machine. And you should see a nice capnography trace, which tells you there's a good seal and that there's carbon dioxide being produced. But you should also see what your inspired oxygen is for the patient, which should be approaching 100%. And that expired oxygen is going to start creeping up from around 20%, and you need to get it above 90%. Now, this is crucial to do. It's one of the controllables. And if you think about it, if you've got 90% oxygen in the patient's lungs rather than 20% oxygen, you've bought 4.5 amounts of time. So it buys you time when you struggle to intubate, or you're not as quick as you will be later on when you experience. So this is absolutely crucial. I never start at the end tidal oxygen isn't above 80%, and I aim for above 90%. Easily controllable thing to do. So everyone gets good positioning and good pre-oxygenation. You then move into choosing an induction agent for your anesthetic. Now you can choose ketamine or etomidate or propofol. Propofol is probably the nicest one to put patients to sleep with. They enjoy it the most. It's the smoothest, but remember, it drops your blood pressure more than any of the other ones. So while we will use propofol as a more experienced anesthetist, the safest one is probably ketamine, 2 milligrams per kilogram, because it gives you some analgesia. It doesn't drop the blood pressure as much. It's easy to use. So that's what I've put in my beginner recipe, but you'll notice that if you do anesthetics later on, you almost never do this. Then you need to choose something to paralyze the patient, either succinylcholine or rocuronium. If you're needing fast muscle relaxants, you can use other ones. Normally for a rapid sequence, we choose succinylcholine at 1 milligram per kilogram. And then you need to maintain your patient once they're put to sleep with either a volatile or ketamine. And normally I turn on something like isoflurane in the range of 0.3 to 1. I usually started at about 0.8 to 1 in my stable patients. And that's a basic induction. Ketamine, succinylcholine, rapid sequence induction, turn on the gas. And that's pretty simple. So that's as simple as an anesthetic can be. Ketamine, 2 milligrams per kilogram, succinylcholine, 1 milligram per kilogram. Maintain on isoflurane. I put ketamine there because it is another option we're going to talk about. And then think of some targets for the anesthetic. Keep the heart rate below 120, the systolic blood pressure above 90, and your hemoglobin above 7. And that's a simple recipe to do anesthetics. Obviously, in between there, we have to intubate. Now, if you're unsure, have a senior there just until you're on the ventilator. 2 experienced hands really help. Even when I'm intubating, I often want another anesthetist in the room because of when I call for things or ask for things, it really helps to have somebody that understands intubation in the room. Notice on this picture, the back is straight. The person intubating hasn't got their head in the mouth. They're standing far back. Look at the direction that the laryngoscope is going to move. Up and away, and they're not rotating their wrist. Those are common beginner errors. And I'm going to take you through very quickly now a way to intubate. If you want a beginner's guide, go to that airwayjedi.com reference that's there and have a read. Very nice instruction manual on how to intubate. Remember that there's something called the burp maneuver, and the burp maneuver is your assistant presses on the cricoid ring. They press backward, so that's when the patient's lying supine, that's downwards. They press to the patient's right, and they push the larynx upward. So it's backward, upward, rightward pressure. That should spell burp. I've obviously got that in the wrong order. And that'll take an airway that looks like this. So that's just the bottom of the arachnoid cartilage as you're seeing, and push it into view. And I often do this myself with my left hand, and then I put the assistant's hand where I want the larynx, and they hold it there for me, and then I intubate. So the burp maneuver is really, really critical. Now, this is basically how you'll go through intubation. I'm going to walk you through the steps, and then I'm going to show you a video. You insert the blade into the patient's mouth, and you sweep the tongue to the left. You then go looking for the epiglottis, not the cords. The first thing you're doing is trying to get your tip of the laryngoscope in the right place, and that's at the base of the epiglottis. people call that the vallecula. So you find the tongue, you slide the laryngoscope down the tongue looking for the epiglottis, and you haven't started lifting that laryngoscope yet. You're trying to position it right as the first thing you do. The tip position you must establish before you earn the right to lift your laryngoscope up and away. Then you lift up and away, you add a burp maneuver if your vision isn't good, and you watch the tube go through the cords. If you lose sight of the cords when you're intubating, it means you don't actually know if the tube went through the vocal cords. So you must watch it through. Now here is a video just to take you through the process. What's happening here is we're putting the tip in. See, sliding down the tongue. We haven't started lifting yet. Looking for the epiglottis. There it is. There's the tip. Now you want the tip at the base of the epiglottis. That's now in the vallecula. And because that tip's in the right place, you've earned the right to lift that epiglottis. So now we're going to start lifting up. You can just see, gone past it now. There's the cords, but you must come back. Tip's in the right place. Now you can lift up. And there you see the cords beginning to appear, the bottom of the cords and the arytenoid cartilages. Those are the vocal cords. And that is the glottis, which we're going to insert the tube through. Now here comes the endotracheal tube, watching it through the cords. And then what we all do when we begin is we push it too deep. That's what you do when you're nervous, when it's a difficult airway. So now they're pulling it back to the right depth. And there's the first, that's the second black line. The first one has already gone through the cords. And you want to make sure that it's at the right depth. And actually what you do is you look at the cuff and you see how far the cuff is beyond the cords. So once you've got the tube in, you inflate the cuff, you confirm it's in with capnography and by listening, and then you put the patient on the ventilator. Now, usually you should pick one mode that you like. In the beginning, the easiest one to learn is volume control. It's not actually my preferred method of ventilation, but it's the easiest one to understand. So I recommend you start with volume control. And you do something like set a tidal volume of around 400 mils. That's something like 6 to 8 mils per kilogram. A respiratory rate of 12 to 16, a PEEP of 5 to 8, and start the patient initially on 100%, but wean back to 40% as soon as you can. And those are basic volume settings. So you pick the tidal volume, the rate, the PEEP, and the oxygen level, and then you watch what pressures you generate. And those pressures should not be too high. So they're normally in the 20s. If you can, pick a synchronized mode. Initially, while your patient's paralyzed, your ventilator is going to do all the work, but then the patient might start breathing. And a synchronized mode will allow the patient to trigger a breath and then give that volume when the patient's triggered the breath. And for a lot of surgery, that's actually permissible. So we're going to intubate, do a rapid sequence. Usually we use a size 7 tube or 7.5, but a 7 will work in most patients. If you fail, you're going to put a laryngeal mask in, which I'm going to come to in another talk, and then we set the ventilator. But remember that the goal is oxygenation, not intubation. So if you fail with the intubation, don't forget the supraglottic airway device. It's an acceptable way to manage an airway if you were unable to intubate. Now we come to maintenance, and you can either use a volatile anesthetic such as isoflurane or sevoflurane, or you can use ketamine. But remember that ketamine, either by infusion or by boluses, is quite hard to keep a patient still. So they may be anesthetized, but they're going to move. So you often need a muscle relaxant of some sort. So I prefer to use the volatile. It's titratable, meaning that if the patient becomes unstable, you can just switch it off. And I use isoflurane in general. Remember that all general anesthesia is always a titration. Healthy patients need a lot of drugs. Sick patients need much less. So during the anesthetic, that amount of gas that you're using to maintain might change. So if the patient is undergoing a lot of pain, you will give analgesia and turn the gas up. If the patient's become unstable or the blood pressure is very low, you'll turn it down. So there isn't a fixed number that you put into the isoflurane. You dial in what the patient needs, and it's always in response to how much stimulation there is and how sick the patient is. So it's always a titration. Don't just turn it to one thing and think that's it for the anesthetic. Give analgesia. I tend to use fentanyl at around 1 microgram per kilogram every 30 minutes while my patient is not yet stable. So if the patient's bleeding, this is what they get from me. But if the patient is stable, you can give them morphine, 0.1 milligrams per kilogram. And don't forget other forms of analgesia like paracetamol or even a non-steroidal anti-inflammatory. Use as many ways as you can to treat pain. It's the key to a stable anesthetic. And what I do is I give lots of analgesia. If I can, I give local anesthetic or regional blocks, and then you need less gas. So you are able to protect the blood pressure better if you do your analgesia well. And then emergence, this is an important phase. Wait till they're hemodynamically stable, they're not on adrenaline, you're oxygenating adequately. Hemoglobin should ideally be more than 7, but at least more than 6. Your temperature more than 35. If you gave a non-depolarizing muscle relaxant such as rocuronium, you must reverse it with glycopyrrolate and neostigmine. And when you're learning anesthetics, always do awake extubation. The complication rate for intubation is 4%. For extubation, it's 12%. And if you think about the room when you intubate, it's always got lots of people, everyone's helping when you intubate, and when you extubate, it's often empty. So take this phase really seriously, and the more of a beginner you are, the more awake the patient must be. So I always say they must be so wide awake that they could almost write you a note saying, please take my tube out. Wait until they're wide awake. This will just stop all the complications such as laryngospasm or the patient's unable to cough. If you pull that tube too early, you can get yourself into trouble. So do it wide awake. And then the post-op recovery period, just one slide on this. Remember that you should put the patient in a recovery area. You should aim to keep them for at least 30 minutes. They should be fully conscious, GCS 15, hemodynamically stable, heart rate less than 120, systolic blood pressure probably more than 100. The respiratory rate must be less than 20, no active bleeding, pain controlled, not vomiting. And if you're not sure, if you think my patient's a little bit on the borderline, but I have to sign the patient out, schedule post-op visits in the next hour or two. And you'll often get a feel for whether that patient's on an improving or a declining trend. So I hesitate to do this, but here's a one-size-fits-all recipe because in practice I almost never give an anesthetic this way. But if I had to tell a beginner over the phone what to do, this is the recipe I would give that person. But ideally you phone someone yourself and talk to them because there's often slight changes that you'll make because of the particular situation that you're in. So you will examine every patient and prepare every theatre. Get the monitors on and a working IV line. Position the patient as if they're going to have a difficult airway and pre-oxygenate for 4 minutes and time it and make sure the end tidal oxygen is more than 90. Give ketamine 2 milligrams per kilogram and succinylthonium 1 milligram per kilogram. Intubate with a size 7 endotracheal tube. Ventilate with the settings I mentioned earlier to keep the CO2 around 5 kilopascals. Maintain anesthesia with isoflurane at 0.8. Give analgesia with morphine, 5 to 10 milligrams IV, and supplement that with ketamine, a milligram per kilogram if you need to. At the end, switch off the gas and extubate the patient awake. And if you gave a non-depolarizing muscle relaxant somewhere in there, like rocuronium or vecuronium or cisatracurium, then make sure you give a reversal before extubation in every single patient. And that's my recipe for just about everyone. That'll work in most patients. It isn't the most elegant recipe in the world, but it will work. And then as you get more comfortable with this recipe, we can start to adjust and fine-tune and make your anesthetics more elegant and help your patients be a little bit more comfortable during anesthesia. And that's all there is to it. Thanks very much. We're going to go through some of those elements in detail in later talks.